This podcast is supported by MedMastery. At MedMastery, you can learn some of the most important clinical skills like echo, advanced EKG, coronary angiography, and PCI basics, pacemaker and ICD troubleshooting, and so much more. All their award-winning courses are CME accredited, and as a sweet bonus, CardioNerds listeners can get an exclusive 15% discount on a lifetime subscription. So head on over to www.medmastery.com/CardioNerds today.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated CardioNerds everywhere are working hard to fight this global epidemic. These are their stories.
Hello, CardioNerds. It's Dan Clark here with Dan A. It's my pleasure to welcome you back to our next episode of the ACHD series discussing advanced heart failure therapies, including mechanical circulatory support and heart transplantation for our ACHD patients. Let me first introduce our ACHD fellow discussant today, Dr. Andy Pistner. Andy is a fellow Northwestern undergrad and ACHD fellow currently at the University of Washington. He completed his medical school training at the University of Rochester and then his internal medicine residency, adult cardiology, as well as advanced heart failure fellowships at the University of Wisconsin before moving to Seattle. Andy, welcome to CardioNerds.
Thanks a lot, Dan. I'm excited to join you guys today with our faculty discussant, Dr. Rafael Alonso-Gonzalez. I have only known Dr. Alonso here through his great work in the field of heart failure in the adult congenital heart disease population. So it's a real honor for me to be able to share the platform with him today. He is a graduate of the Universidad de Navarra in Pamplona, Spain, before pursuing his cardiology training in Badajoz and Madrid, Spain. And then he went on to London for additional training in adult congenital heart disease, where he stayed on at the Royal Brompton and Harefield hospitals, where he's the lead clinician and coordinator of their advanced ACHD heart failure service, which included the combined ACHD transplant clinic. More recently, he has joined the University of Toronto, where he is now the director of their ACHD program. So welcome.
Thank you very much for the kind introduction. It's my glad pleasure to be here to share with you guys this amazing initiative that you have put in these episodes together. So thank you for inviting me.
So Dr. Alonso, as an ACHD fellow myself, I'd love to hear how you got interested in adult congenital heart disease.
So that's a long story because actually it was by accident. So I finished my training in cardiology and was really interested in pulmonary hypertension. So I trained in pulmonary hypertension in Spain, and my mentor told me that if I wanted to be good at pulmonary hypertension, I had to do a fellowship in ACHD. So then that's what I did. I applied to the fellowship in London, and I went to the UK with all intention to train in ACHD and come back to Spain to be a pulmonary hypertension doctor, join with ACHD. But I fell in love with specialty, and I just never left London. So I went back to Spain for a year and came back to London afterwards, but never left the field. And from London came to Toronto, and that's motivated me to continue to do ACHD. But I started in this, I have to accept, accidentally.
That's awesome, Dr. Alonso. It's fun to hear your story of how you got to the field. I think, like many of us, we not necessarily started out myopically focused on ACHD at the beginning, and then once we had a taste of it, we're stuck. We're hooked. Thank you for sharing. Andy is both an ACHD and advanced heart failure doctor. I'm really excited to hear your unique perspective on this topic. So to start, let's review the scope of the problem. How many ACHD patients have heart failure? How fast is this population growing?
Yeah, Dan. So this is a really big problem, and it's a challenging question to answer, in part because of the challenges in collecting data about this group. There's a lot of heterogeneity in both the underlying anatomy, the surgical repairs and palliation, and there's really no standard definition of what is heart failure in the adult congenital heart disease population. But depending on what groups you look at, what resources you use, you can pretty confidently say that heart failure is the leading cause of death amongst patients with adult congenital heart disease. And depending on how you describe what classifies as heart failure, you can see that in a large portion of the patients. A study from Europe saying that there's approximately 22% of patients who've undergone an atrial switch procedure have symptoms of heart failure. Similarly, you can see that in probably up to 40% or so of patients who have a Fontan palliation. But again, this all kind of comes back to what would you say is heart failure and what is not heart failure? Some people would probably go as far as to say that everyone who has adult congenital heart disease has heart failure because they have structural heart disease. But that might be taking it a little bit too far.
So I think that is absolutely true. What we have seen, I've been doing congenital heart disease for quite a while. And we have seen a change since it's true that the main cause of that is heart failure, but we have seen a change in how patients present. And with the young population, you're still having arrhythmias as a main cause of problems for them. And where as soon as they turn 40, we have already enough evidence to see that above 40 heart failure is the main cause of that in this population. And one of the problems that we are having is that, as Andy said, this is a very heterogeneous population, and having heart failure treatment for all of them and being able to make a guideline that tell us how to treat these patients is challenging, if not impossible. And that is one of the major problems that we have, as well as their access to advanced therapies and transplantation makes quite challenging to treat this population. But at the same time, it's very exciting and one of the most interesting part of the field, in my opinion, although I'm biased.
It's okay to be biased. And thank you both for that information. So obviously this is a tremendously heterogeneous group and patient population, and this is going to definitely make things quite a challenge in order to study which patients will do best with transplant. But Andy, how many patients with ACHD end up actually undergoing transplant or requiring mechanical circulatory support?
One of the papers I like to point to people when answering this question is the study from Brian Maxwell and the group at Stanford, who published a study using the U.S. transplant database called the Scientific Registry of Transplant Recipients, or SRTR for short. And essentially, this is the database we use for transplant in the United States for all these studies. And they found that the proportion of heart transplants for congenital heart disease has been steadily increasing since the late 80s. And between 2010 and 2012, accounted for about 4% of all the transplants that were performed. And then as far as mechanical circulatory support goes, that's an even more challenging question, again, just because the data is significantly more limited than what we see in our non-ACHD counterparts. But there's another great paper from Christina Vanderplum and Ari Cedars that's in the Journal of Heart-Lung Transplant from 2017 that looked at the Intermax registry, which is kind of an equivalent thing for mechanical circulatory support in the United States. And they found that of the 16,000 or so patients in their 10-year study period, only about 126 adults were identified as having adult congenital heart disease with mechanical circulatory support. However, this small group of patients did notably have a comparable survival to their non-ACHD counterparts with a systemic ventricular assist device. And ACHD patients, if you look at other parts of the world, such as the European equivalent registry, which is appropriately called Euromax, you see a larger portion of the MCS recipients have congenital heart disease, but smaller numbers there than what we have in the States.
Thanks, Andy. Dr. Alonso, I'm really curious what you think of these numbers. Given that about 1% of the population has congenital heart disease, it seems like that's a low percentage of patients. And since heart failure is so common in congenital heart patients, it seems like it's a low number of patients going on to advanced therapies. Do you think we're potentially underdiagnosing heart failure in ACHD or more under-referring, or is it a combination? I'm curious what your thoughts are.
I think the short answer probably is a combination of the two. So I think one of the main problems comes from us as a providers, that we are treating patients that are used to be limited, and we fail to identify those signs that are actually signs of getting worse into this, what we might not having a definition of heart failure, but there are signs that you can highlight to identify in patients with, for example, frontal circulation or systemic RVs, that can trigger that referral to the heart failure unit or that process of starting the transplant route in this patient. So that's one of the main problems, identifying the population in a chronically limited patient. The second problem is the lack of congenital heart disease doctors doing heart failure. And this, again, is a bias because this is what I do and what I've been doing for the last 7 years of my life. But having the patients referred to be assessed for transplant in a transplant unit with no ACHD input makes these patients less suitable for being assessed properly when come from time into transplant, or even to offer them a heart transplant. The third problem that I see is the listing criteria have recently changed in the US and Canada. We're very lucky because we have the congenital heart disease patients have priority for many reasons, but not having a listing criteria different from the congenital heart disease patients compared with non-congenital heart disease patients is a problem. And I think make them less accessible for transplant or advanced therapies. And probably one of the main problems is that who does the transplant? And that is, for me, a key factor. So when I started on doing congenital heart disease heart failure, I asked one of my friends that was a cardiac surgeon, non-congenital, and this is back me practicing in Spain, why don't you transplant a fontan? He was very honest. And look, if you get a phone call at 3:00 in the morning that you have a heart offer and you have a dilated cardiomyopathy or a fontan in the list, and both of them are at the same level of status, then I choose the dilated cardiomyopathy because it's a transplant. And that was an honest answer that shocked me. But actually it's true. If you never had done a fontan before, you cannot be transplanting a fontan. And that's my bias. But I think that one of the major reasons why we have less transplants in congenital heart disease is because our congenital heart disease surgeons are not as involved in transplant as they should be.
Thank you, Dr. Alonso. I had not appreciated the surgical considerations of approaching a patient with adult congenital heart disease for transplant. In my simple mind, I thought swap it out, swap it in. But obviously, you raise the complexity of it by thinking about the prior anatomy and how to actually make it work. And so I appreciate that very much. And Dr. Alonso and Andy, if I'm getting this down accurately, it sounds like we may both be under-treating heart failure as well as under-referring these patients for advanced therapies. Andy, are there just too few providers and centers capable of taking care of these patients?
That's a great question. I think that accessibility to care and expertise are certainly components of the problem. But like Dr. Alonso was saying, the organ allocation systems that we use to prioritize patients for transplant play a really pretty large role here as well. And as he pointed out, we have different allocation systems here in the United States, and we only recently updated ours in about October of 2018. But that system is very different than the Canadian system, which is different than the systems used in different countries in Europe or Australia as well. And this is true kind of across the world. And so kind of comparing them from region to region is a real challenge because you're kind of working in a different set of rules for every place that you are. But that being said, it's really hard to discuss the American allocation policies, which is what I'm obviously more familiar with, having trained here in the States, and how they impact the adults. You really can't discuss this until you talk about two kind of key papers. One is Melanie Everett's 2011 study, which is in Journal of Heart-Lung Transplant, and then Laith Ashawabke's paper in JACC from 2016. And the take-home from this first paper is that patients with congenital heart disease who are on the heart transplant waitlist are less likely than their counterparts to receive a transplant. And this really holds true even when you divide them by their initial listing status. And then the second paper, where we look at the other side of the issue, is how often do these patients die or become delisted while they're on the wait list? And they found that patients with congenital heart disease who are listed at the highest possible urgency status, and this is in the old system, so the patients who are listed as 1A were more likely to die or be delisted, presumably due to clinical deterioration compared to their non-ACHD counterparts. That being said, aside from policy, there are unfortunately multiple other potential transplant barriers for patients with congenital heart disease. And that includes sensitization, meaning that they have developed antibodies that would make them potentially challenging to not be a good recipient for certain donor organs. In Canada, they actually are kind of leading the way in this, and that part of their prioritization policy is that they actually have a listing status for those patients who are highly sensitized. Unlike United States, which there is no such component, although it's been pretty extensively discussed at the transplant meetings. Similarly, there's issues with donor-recipient size matching for the allograft, psychosocial barriers, and other anatomical or surgical considerations that can make this more challenging for patients.
It definitely makes sense. And thanks for that, Andy. But how do adult congenital heart disease patients do once they do end up getting advanced heart failure therapy, such as heart transplantation? So do patients do worse given their prior complex anatomy, as Dr. Alonso brought up earlier? How do they do, especially compared to their counterparts without, such as the dilated cardiomyopathy patient that we alluded to earlier?
Yeah, and this is the real crux of the issue here. we have known and continue to see for decades now that patients with congenital heart disease who are transplanted have a worse early mortality compared to their non-congenital heart disease counterparts. So if you look at their survival curves up to a year, patients with congenital heart disease receiving a heart transplant perform worse than those patients who have a non-ischemic cardiomyopathy and some other forms of indications for transplantation. But if you stratify people, once you look at patients who have made it out to 1 year, what you actually see is patients with congenital heart disease perform significantly better than their counterparts who are listed for other indications. And so you have this trade-off that patients do worse early, but they do better if they make it out to a year. And I think one of the things that we have to kind of always keep in the back of the mind is that that curve is getting closer and closer over time. That is to say, we're making progress in cutting down those early mortality losses in that first year.
So I totally agree with that. The data that we have available since that these patients have a high early mortality, but of course they do much better afterwards. However, the new data that are coming out are telling us that we can be as good as the non-ACHD transplanted patients in the early period if we work together and we have a proper team and we work from the patient selection. I think in my personal opinion, one of the problems why we had such a big mortality in the historical cohorts is because, as I said earlier, if we tend to identify these patients too late and send them too late to a transplant. So if you transplant somebody that is very sick, then the patient's going to do worse, right? But we here in Toronto, for example, now our mortality is equal than the mortality in non-congenital patients. I'm talking about early mortality. The long-term survival is better as the HLA data shows, and as Andy said. But I think one of the key factors is that we have a team that work together from the patient selection, patient follow-up, anesthetists, surgeons, post of the period, and discharge of the patient. So it's a quite robust teamwork for making these patients to succeed throughout the transplant. And every single detail has to be watched throughout the period.
Dr. Alonso, it sounds like really systems of care are critically important in terms of collaboration and bringing different providers together so that we identify these patients, get them referred and evaluated early on, and then get to appropriate timing of more durable support for them. So, I wonder, what are some of the systems that are in place to try to improve the outcomes of these patients? Or like you mentioned, in terms of what you guys are doing locally in Toronto, have you heard or seen other systems of care being implemented globally to really address this problem?
Before I came here, so in 2012, Toronto started an ACHD heart failure clinic, which implies that before that time, every single patient that was referred for transplant was referred to the heart failure team or the transplant team. Since then, every single patient referred for transplant is referred to the heart failure clinic. And the idea is the patient is being referred to the heart failure clinic as soon as they develop heart failure. This is exactly the same model I had in the UK. And at the Bronton. So every patient with heart failure, we had some criteria which is beyond to the point of discussion today, but we had the specific criteria where the patient should be referred to the heart failure clinic. So patients come to the heart failure clinic, and some patients will go to transplant assessment, some patients will go to treatment optimization, but they continue to be followed up in the heart failure clinic if transplant is going to be what they're going to need long time. Some patients come to the heart failure clinic, they improve, and they go back to their own clinic. And when we decided that the patient is going to be transplanted, then we have a team of people that sees the patients, always the same team. So we have one of the biggest changes we did is the transplant was done before by the general cardiac surgeons. Now it's done by the congenital surgeon. So every single patient is seen by the congenital surgeon and by the general cardiac surgeon as well. We have 3 anesthetists working on the transplant group, and one of the 3 will see the patients beforehand, and we discuss the patient in our rounds, in the congenital rounds. If as a team think that the patient is transplantable and it's going to be a successful transplant, then we discuss the patients with a heart failure team. Heart failure team also assess the patient before the discussion in the heart failure rounds or in the transplant rounds. And where after the patient is assessed by us and by the transplant team. We together in the transplant rounds discuss the patient, but by then we have already probably had agreement on the patient. If the patient goes into the list, for example, for the Fontan patients, we decided how far we're going to allow the donor to be. And normally we just choose local donors. Where the main work starts is the day of the transplant. So when the patient is called for a transplant, we are two people here doing heart failure in the ACHD group. So one of us is going to be in the hospital from the time that the patient is called. We will work together with the surgeon and the anesthetist pre-transplant. I personally physically in the OR during the whole transplant. If it's a Fontan, if it's a biventricular heart, probably not. But in every single Fontan, I'm physically in the OR. And I think that's important because what's happening in the OR might determine what is going to happen immediately postoperatively. After we work very close with the transplanting, as soon as the patient is transplanted, go to the ICU, and from there we work very close with the heart failure team and the ICU team to just control every single. It's like a micromanaging of every single metabolic change or heart rate change, a physiological change of these patients. You have a Fontan that you change the heart, but the patient is still having a multi-organ failure after the transplant. It's a patient that had a Fontan for 25, 30, 35 years. And because you give them a new heart, you don't make them already a normal circulation. And I think that is one of the main issues where people die. The biggest mortality occur in the perioperative period. And I think this one of the main concepts to change that mortality is having the ACHD team involved in that period and thinking that what you are treating is still a Fontan, but with a normal heart. So it's easier, in my opinion, to treat somebody that doesn't have a low cardiac output state, but is still having a kidney that doesn't have reserve, a liver that doesn't have reserve, a gut that might be a problem, and suddenly the body is not used to have normal cardiac output, so that's going to have a reaction. So I just can give you guys an example. In the last Fontan transplant that I was present, the patient was a very, very high-risk patient. So she had a drop in blood pressure during the induction and significant drop in blood pressure. We thought that we almost lost the patient. We managed to get her back, but it was only 3-4 minutes, no more than that. And that had a massive impact on the liver. So in the first 12 hours, her liver had a liver shock, which I knew exactly why that happened. I knew exactly what to do. And I didn't freak out because I knew that because of what happened in the OR, and therefore I knew that would be resolvable. If I hadn't been present in the OR, I would have thought that something was wrong at that time and something was going wrong with that patient. I might have made different decisions for managing that patient. That patient was discharged in day 10 and she went home 10 days after her heart transplant and is doing fantastically well.
Wow, it sounds like you have this major multidisciplinary coming together between a group that thinks, lives, and breathes transplant all day long with a group that lives and breathes congenital heart disease all day long, and utilizing the machinery of the transplant machinery that's set up for the general patients with, advanced heart failure and connecting in adult congenital patients using that machinery, but then having that by play interaction together is really a setup for success for your patients. Andy, is there any other thoughts that you have on this subject?
I think he hit the nail on the head here that thinking about these patients not as a usual heart transplant patient, but rather a Fontan patient who now has a quote normal heart really kind of changes the paradigm about how you look at them. How do you interpret the information you're getting in that early perioperative period, which is kind of the make or break time for a lot of these patients. I'll just echo what he said, that I think that the key to success for this group of patients in reducing these early adverse outcomes is that we are performing transplants at centers that have expertise in congenital heart disease, and maybe even more so, places that have expertise in doing congenital transplants, which are not inherently the same thing. But I think we're starting to get some really good data to suggest that if you do congenital transplants at higher volume centers, the patients are going to do better. And this is true both in the early and in the midterm as well. And then we started to recently here in the United States have this American Congenital Heart Association accreditation. And there's a great paper by us, but it's from our group here in the University of Washington that says if you look at patients who are on the wait list, who at an institution with this ACHA accreditation, they have lower waitlist mortality. But then if you look at the groups that have the highest congenital transplant volume in each of the UNOS regions here in the United States, those hospitals as a group have better 1-year mortalities than the rest of the hospitals that do congenital transplant. And so I think that there's a really strong argument, and a stronger argument by the day, that regionalization of congenital transplant to improve outcomes is one of the ways that we can really help get this curve more in line with our non-ACHD counterparts. It's a challenging question to try and figure out how do we do that equitably and making sure that all patients have access to that care, especially if you're really rather remote. I think places like Canada are somewhat leading the way in this area, and that not necessarily every congenital transplant is being done at every transplant center in Canada, but rather they're focused and more of them are being done in select centers. And I think that we see that here in the United States, that if we kind of clustered where we're doing our transplant, we may do a lot better than we're doing right now.
Well said, Andy. This has been a really fun discussion of the scope of the problem and some of the unique nuances of caring for patients living with adult congenital heart disease and heart failure. So what do you say we apply this to a case?
Oh, Dan, I completely agree. And this is one of Amit's favorite parts of these episodes. And this gives us a nice opportunity to wish him happy anniversary to him and Riddhi. And we're glad that he made the wise choice of sitting out this recording so he could spend the day with his family. So kudos, Amit. We miss you. But definitely, Andy, share a case with us so we can review some of the things that we've said earlier.
Sounds good. So the case here, we have a 36-year-old female. Her original anatomy was that of a double inlet left ventricle with L malposition of the great arteries. Initially, she underwent a classic atriopulmonary Fontan palliation, which was complicated subsequently with multiple atrial arrhythmias and multiple ablations before undergoing a Fontan conversion to an extracardiac conduit. And then she has several veno-venous collaterals, which have been previously embolized or occluded. And she also has developed protein-losing enteropathy. At this point, unfortunately, surgical and percutaneous interventions have been exhausted, and she is now being considered for advanced heart failure therapies. And so the question we pose here is, how is her evaluation different than a patient who has conventional anatomy?
Oh, wow. Hold up, Andy. I think I got this. I'm immersing myself in this adult congenital series. So I'm having flashbacks to our awesome 2-part series on Fontans with Danielle and Dr. Yuli Kim. So this patient has passive pulmonary blood flow through the Fontan circuit, which was converted for better efficiency from the classic atriopulmonary Fontan to the extracardiac Fontan. The blue blood from the IVC goes through the extracardiac Fontan, a fixed surgical tube that doesn't grow, as Dr. Kim pointed out, up to the right pulmonary artery. The upper body blood drains via the SVC directly into the right pulmonary artery via a bidirectional glen. So blue blood turns into red blood, and then this oxygen-rich red blood returns through the pulmonary veins to the common atrium and has 2 ways to get to the left ventricle, the tricuspid valve and the mitral valve, before getting pumped out of the left ventricle across the VSD to the aorta, which arises from the right ventricle. So how did I do with that anatomy?
Dan, you nailed it. So apparently you have been doing your homework during this series. Congratulations. Dr. Alonso, this case is obviously pretty advanced. How would you think about the evaluation for this patient differently than our non-ACHD patients?
When I was listening to the case, there's one thing came to my head is that the first thing I would think is, well, this patient has an excess sternotomy for his spontan conversion. Is going to be that a problem for a new transplant? So before we consider to convert patients here, we see whether a transplant would be a better option, because every time that you do an excess sternotomy, apart from increasing the risk of the transplant, you might make a patient not transplantable if you get the structures to stack on the sternum. But having said that, how would I approach this is a difficult question, and with multiple parts of the answer. So one of the main problems when I face a transplant in a Fontan patient, this patient is quite advanced, and is no doubt that needs a heart transplant, but sometimes that's not that clear. Making the patient to realize that they need a heart transplant is a challenge, and that's for me is one of the biggest challenges. Sometimes you see that things are failing, but the patient doesn't say it, and to convince the patient that needs a heart transplant is difficult because they feel okay. They have been limited themselves throughout their lives, and you do an exercise test and the peak VO2 is 9, but they're still feeling okay because they have adapted to that exercise capacity over time. So for me, that is one of the biggest problems. The second problem in a Fontan patient, every time that I approach a transplant assessment, I look at the Fontans as a multi-organ failure. And I think that's one of the key factors when you assess these patients, and something that I learned, that even if the kidneys look okay, they aren't okay. So even if the patient has a normal creatinine, those are kidneys that have been in low cardiac output since the day one, that since the Fontan was completed, it's a low cardiac output state, and the kidneys are probably at the maximum that they can give, and they don't have much reserve. So you might have a normal creatinine, but you know that that's going to be a problem afterwards. The liver, what I'm going to say about the liver that is not written everywhere, since the biggest problem when assessing these patients, do we need to do a liver transplant along with a heart transplant? Is a patient candidate for a single heart transplant? Assessing the liver is one of the biggest challenges for these patients. Again, something that the patients sometimes do not understand, and you just tell them, well, we're going to assess your liver, you might need a liver as well. So, well, I only have a heart problem. Why my liver is a problem now? So assessing the liver is a big deal. And I don't think we have the answer which patients benefit from a heart and lung or a heart alone. And we are pretty much in our center, a heart alone if possible. The second problem is the pulmonary pressures in Fontan, because assessing the pulmonary pressures is challenging when you have different pulmonary blood source. But actually, I'm not sure that makes a huge difference. The problem with the Fontan, you're always going to underestimate the pulmonary pressures. And it's very well recognized literature that these patients have always after the transplant higher pressures than they had before. And the underestimation comes from source errors. So as I said, you have different pulmonary blood flow sources, but also because you have a low cardiac output state, and therefore if you have low pulmonary blood flow, your pulmonary vascular resistance is going to be low no matter what. But I don't think that's a big deal afterwards, something that that you might have to deal with postoperatively, but shouldn't be a big issue. Sensitization is another problem, that these patients are highly sensitized because of previous operations or not. And that's why, coming back to my point at the beginning, every time that you're going to do another heart surgery in these patients, you have to consider if you're going to increase the risk of sensitization, and after these patients are going to have less chances of having a transplant. And that's something that I always consider, or when you think about giving them a blood transfusion, if it's not needed, you might want to hold back and not to give it, right? And one of the biggest issues that we spend more time here is in the technical issues of the heart, of the transplant in these patients. So we always talk to the surgeons. As I said earlier, we involve our congenital surgeons because they are the ones doing the transplant. The main issue is the sternotomy. And the biggest question is this patient, is the sternotomy safe? Why I say this is because every surgeon can tell you, well, you always can do a femoral bypass, put the patient on bypass before opening the chest, and every chest can be opened with a femoral bypass. But we do know that if you do a femoral bypass in a Fontan and you don't have a graft very close and very early in the OR, and the longer you keep the bypass time, the higher is your risk of mortality in the Fontan patient. So we try to open the chest with off bypass, and we try to avoid the patient on bypass until we know that the organ is going to be in the short time within the OR. So it's true, there's a way of getting away with having a aorta stacked to the sternum, but we know that if you have a Fontan that is already borderline with a lot of multi-organ failure, and you're going to have a longer bypass time, then you're going to increase your risk of mortality. And the second problem is these patients is a double inlet, and probably technically the only problem is the transposition. But if you have a left atrial isomerism, dextrocardia, then with a bilateral glen, you have to think about how you're going to fit the heart there, what connections you're going to make. And also you have to plan in terms of the donor. We always tell whoever is going to harvest the heart what we want: extra aorta, extra SVC. So if the patient has a left SVC, we always bring a larger innominate to connect the left SVC to the innominate. So you have to plan how you're going to do your connections before even harvesting the heart, because you might end up not having enough tissue to do the whole reconstructions, which is another factor to increase mortality in these patients. So all of that you have to have it in mind. And that is why for many of the things I said, you need somebody trained in ACHD, both clinically and surgically, in order to understand many of these issues.
Wow, Dr. Alonso, that is such a fantastic overview. Thank you very much. I really loved how you emphasized from the patient's perspective, because I think that's something I've appreciated this year as an ACHD fellow, is really how much some of our Fontan, or most of our Fontan patients, have been so resilient over their lifetime, adapting to low cardiac output, and that often they may not even appreciate some of the subtle changes that have chronically been taking place. And so, a lot of times the first step in the battle really is convincing our patient that something has changed significantly, and then we're now really moving on to advanced therapies. So I think that's an excellent point that you brought up, in addition to so many other excellent points. I'd love to hear a little bit more just about how you would kind of uniquely think about the consideration of heart and liver versus heart alone.
As I said earlier, we always try to do a heart alone instead of heart and liver every time that's possible. So we have the liver team here is heavily involved in the decision making. So we have our liver doctors that follow up our patients, and when they develop Fontan-associated liver disease, and mainly if they have nodules more than 1 centimeter, they are always assessed by the liver team every 6 months, even before transplant is considered. When transplant comes into place, then all of them are, even if they weren't on the liver assessment, are assessed by the liver team and by the clinical liver team and by the transplant. We don't do routinely liver biopsy. We only do biopsies in patients that might have a suspicion of ACC. Otherwise, we don't do liver biopsy to decide whether or not the liver is transplanted. It needs to be transplanted. And we basically do it based on liver or synthetic function of the liver and imaging. So every single Fontan liver is fibrotic, no matter what. And few of them have a severe advanced cirrhosis that needs a liver transplant. And one of the main factors that can help you to make that decision is the size of the liver. The bigger the liver is, the better the liver is going to be. The smaller the liver is, it's just the worse the liver is going to be, because that means that the liver is so fibrotic that it becomes very tiny, and small livers actually is a bad thing for transplant. So we have a very close collaboration with the liver team. So far, while I've been here, we haven't transplanted any heart and liver. So all of our transplant Fontan has been transplanted with just a heart. Many of them with, I would say, with advanced cirrhosis, but normal synthetic function. And the good thing is that we follow them afterwards. But we have seen that actually the fibrosis improve over time. And I think that is the data we do not have. I think we do not have the degree of improvement afterwards. I think many teams have moved to do a heart and liver transplant in every single Fontan. Probably there are new data say that might be better for the heart to do a heart and liver, but you are using 2 organs in one single patient, and you increasing the risk of the transplant because it's a dual organ transplant, and the liver is not an easy transplant to do. There's a lot of debate whether you should do a sequential liver heart or do a simultaneous liver heart. So this is not even something that we have answered. As I said, all of our Fontans transplanted in the last 3 years since I've been in this institution. And when I was in the UK, we only had 1 patient with a heart and liver as well. So majority of our patients been transplanted just with an isolated heart, and they do well and the liver gets better. So the problem here is we do not know what are those criteria for when the liver is not going to cope. And that's, for me, exciting part of the field, because it's an area where we have to work together with the liver teams. And I don't think the answer is giving everyone a heart and liver. I think the answer is for us to identify which are those predictors that are going to make that liver to fail, and therefore that patient benefits from a heart and liver. And what are those predictors? Actually, you can say, well, this liver is going to do well, then I won't transplant the liver. So it's a challenging question with no answer. I do not have the answer. And I don't think I will have it in my lifetime. But I think it's a field where we have to work extremely close with the liver teams. The main problem is to find a liver doctor interested in Fontan liver, which I'm very lucky that I have one.
I really appreciate that perspective, Dr. Alonso. Our center is a high volume heart transplant center and do both heart alone and heart liver. And I think you really emphasized a lot of the pieces of this debate that is such a central debate in the ACHD community about whether or not to do heart or heart liver and Fontan patients. I love the fact that you really brought home that collaboration is so essential, and creativity, and really this new frontier of unknowns, and setting out to answer some of these questions. Those are pieces of ACHD that really excite me and keep me so interested in the field. I did want to ask one kind of follow-up question that is very transplant specific, but I think is highly relevant now with the Hep C donor era. So how does that change your practice in terms of consideration of Hep C donors for these patients? Is that on the table if there's associated liver disease?
It's on the table, and our decision has been not to offer Hep C donors to patients with fontan hearts. We do it in the non-fontans, and we have transplanted one with but non-fontan. In the fontan patients, we have decided not to do it. There is completely no data. It's just because you are scared that what it might happen. Nothing might happen, but until we have more data, we have decided not to use a Hep C donor for fontan patients. But that might change in the future. We have started the Hep C donor program just, I think, last year. So far, they are doing very well in the non-congenitals, but the fontan is unknown, and probably might be okay, but it's already another extra risk of a high-risk transplant already that we do not want to take at this stage.
Dr. Alonso, you've given us quite a lot to consider, especially in patients who have often had multiple sternotomies and non-traditional anatomy. For our patient, I know we've already tried to hold off on heart transplantation to this point, but just to be sure we've exhausted everything in our arsenal, Andy, what are some of the interventions that may help obviate or postpone MCS and transplantation?
So some of the things we think about when we're looking at a patient like this is a couple of things. Is there anything we can do to kind of restore a more normal cardiac circulation, or at least help support their cardiac output, or address maybe some of the issues about why is the patient becoming symptomatic or running into other comorbidities now? And that would be things like, is there significant systemic atrioventricular valve regurgitation that is leading to a less efficient stroke volume? And then kind of further on that point, if you have a patient who has significant systemic atrioventricular valve regurgitation, you can always consider some sort of intervention to help reduce the regurgitation and improve their effective stroke volume. And this may, in fact, require another cardiac surgery. But as Dr. Alonso pointed out, you're going to further potentially sensitize this patient against potential donors down the road. And it's difficult to kind of figure out what the arithmetic is there in terms of how much time you're going to be able to buy the patient by doing this. If it's a really young patient and the only real issue with their fontan is that they have systemic AV valve regurgitation, maybe it makes sense to do another surgery to help fix that. But if they're starting to really head towards transplantation, you have to ask yourself, should we start to think about primarily fixing this problem with a heart transplant versus the trade-offs you would get with doing another valve surgery? Similarly, we can look at doing interventions on veno-venal collaterals and other percutaneous options that might be available for these patients that are really rapidly developing here in the past decade or so. But at the end of the day, I think that things that we would think about in the conventional heart failure population or acquired heart failure population, like using guideline-directed medical therapy, is going to be a lot more challenging to extrapolate to our patients with congenital heart disease.
Yes, I think that's a great point, Andy. You bring up guideline-directed medical therapy, and for a lot of our patients who have systemic RVs, what is guideline-directed medical therapy, and what has been published, and what is the definition of that? So I think you raise a critically important point there, and another curveball for our ACHD patients. What about, this patient had protein-losing enteropathy. Are there any specific PLE therapies that you think of before heart transplant, Andy?
Well, I think there's been some really interesting early work that's come out from your institution with Dr. Menachem, looking at the use of midodrine in some of these patients. And even though it's really a small case series, what they saw was patients with PLE who were treated with midodrine had improvement in some of the biomarkers we use to follow them. Things like albumin, IgG, those all trended towards improvement in those patients who were treated with midodrine. I think that other things that we can think about, lymphatic interventions, they're being really led by some of the ACHD centers here with MR lymphangiograms and then doing percutaneous interventions on those, is a really interesting idea. I don't know that it's going to be the answer for all of our patients with fontan circulation or congenital heart disease in general, but these are things that we're starting to think about as part of our temporizing measures for patients with transplant needs?
That's a very interesting topic. PLE, it's one of my areas of interest. And I think one of the problems with PLE is that PLE has different mechanisms of action. So we don't know why PLE occurs. That's the first point. And there are several factors involved in PLE, probably. And probably with no single medication that acts everywhere where the PLE mechanisms are. Just going back to your question of midodrine, I have to say that I read the paper coming for your institution, and I decided to use it. And I have to say that was the biggest success I have had with PLE so far. I can share the case. It's a patient with a left atrial isomerism with dextrocardia and transposition, and he has an extracardiac fontan. PLE diagnosed at the age of 6 and been treated with sildenafil, steroids, subcutaneous heparin, and all of that comes to adult. With 18 years old, with that treatment, every 3 to 4 months since he's been in the adult, transferred to the adult, he was admitted with this funny abdominal pain that we didn't understand. But every time that was admitted with abdominal pain, he had an albumin of 18. I was recurrent, and we ended up thinking that were bouts of PLE. So I started with increasing his steroids. Did not work. I tried him octreotide, and this is when you use octreotide means you are desperate, because it means that you have nothing else to offer. He did not tolerate the octreotide, had side effects, I had to stop it. So I decided to start midodrine. And after 19 years, which is 19 now, his albumin, 3 months starting midodrine, went up to 40, and he's been in 40 for a year. And his abdominal pain disappeared, his admissions have stopped. So probably what the hypothesis behind midodrine is that midodrine might have an impact on the lymphatic vessels, which is, along with the octreotide, the only drug that has a possible impact on lymphatic vessels. And I think these PLEs that start very early in life, in childhood, has a huge component of lymphatic vessels. And we do not have, well, first of all, we do not understand the lymphatics. So that's to start with. It's something we start in university and we forget forever. And second, we do not have any good drug that actually target the lymphatics. So this is a good example that this patient was treated for the afterload reduction component with sildenafil, was treated for the inflammatory component with steroids, was treated with deficit in heparan sulfate with heparin, but was not treated for anything with the lymphatics because we do not have a treatment. That's why using octreotide was where my head was about. My head was, okay, if this is a lymphatic problem, let's see if this works. And midodrine actually changed his life. So he actually put 5 kilos. He was getting to that stage of PLE that I was thinking of transplanting him. Otherwise, had a fantastic fontan, pressures in the fontan are 10, and his ejection fraction is normal, has no valve regurgitation, so has a fantastic fontan, but was getting to this stage of PLE that if you don't transplant them, they're going to die. And actually, midodrine made a difference. So I think we need to learn more about the lymphatics. I agree with Andy in terms of lymphatic invasive treatment. So in getting these vessels occluded and see whether we can buy some time to these patients. As Andy said, you have to think twice when you offer a patient an operation for a valve regurgitation if that patient is not already on the transplant route. But in terms of PLE, I think we have a lot of room and a lot of things to learn, because I'm not a fan of transplanting patients with fontan just for PLE. And I try not to do that because or if otherwise the fontan is okay and just is PLE, to try to do something. And I think this patient, we have bought him some time. He will need a transplant no matter what, but I think we have bought him some time. So that is my experience. I have another 2 patients with midodrine, but it's too early to say whether that works or not. But in this patient was a truly success.
Thank you for sharing that, Dr. Alonso. That's fascinating to hear. So obviously, a lot of our patients with fontan failure can be incredibly complex. Dr. Alonso, you practice in multiple countries now and have been at different institutions that have a lot of experience with this. Do you have anything that you could uniquely share about the different environments where you've practiced and how things are different, and suggestions for best practices that you've seen?
I've been very lucky and probably too spoiled, because I have the lack of working in ACHD in probably one of the 2 largest centers in congenital heart disease in the world, in the Prompton in the UK and here. So in terms of practice between the 2 centers, probably is not much a difference in terms of the kind of population we're dealing with. So we have a quite probably all the population than average centers, because both centers started surgery quite early. So average age of our population is around 40, 45, and we have more heart failure probably for a single institution at other centers. If I learn anything, if you really want to do heart failure properly, you have to have ACHD doctors training heart failure. I think what Andy is doing is fantastic. Having had a heart failure fellowship and after doing a ACHD fellowship is the best thing that we can try to achieve, to offer a good heart failure treatment to our population. And you're talking just about transplant, and talking even during the time that they are just in heart failure, and you can optimize them in your heart failure clinic. I think I have to point out something different between the two systems. It was that the listing in the UK is different than the listing in Canada. So I think patients in Canada with congenital heart disease have a higher chances of being transplanted. And the UK just recently has been changed the listing criteria for congenital. I still think are suboptimal, but the majority of our patients were on urgent list or no urgent list. As Andy pointed out before, we have something here that is patient is hypersensitized. They go to the top of the list, no matter what. And if you are more than 90% HLA, you just are top in the country. So it's called 4S. It's our maximum, the higher priority. And any heart in the country is offered to that patient, no matter what. That made a huge difference in the chances of patient getting a transplant. For me, a patient with a HLA for 90% in the UK was not transplantable. I already had transplanted one here since I'm here, one or two. And that is because of the change in the listing criteria. Those patients are normally patients that are stable, are at home, have HLA of 90%. You cannot put them in hospital because it's going to be years waiting for a heart. And the chances of having a heart are higher if you have that kind of listing. Otherwise, I think the thing that I would say is more important is collaboration. As I think I probably repeated this word several times throughout this podcast. Collaboration means that you have to have not just collaboration with your transplant team or with your surgeons. Just think outside your ACHD team, your hepatologist, your anesthetist, your ICU. So all of that shouldn't happen isolated from the ACHD team, and we should try to really work together. I enjoy something about Toronto is that the Bronton is a standalone cardiac hospital. Only have cardiac, pediatrics, and respiratory. And if anything, I like working in Toronto. I work now in a normal hospital with a multidisciplinary team. So in London, calling the hepatologist was calling another hospital, whereas in London, it's just calling somebody that is 2 floors up. His head office is 2 floors up, and it's easier to have this interaction and this working together collaboration type thing.
Thank you for sharing that, Dr. Alonso. Andy, do you have any final thoughts on this?
Well, first, I'd like to say that I really appreciate hearing the perspective of what we're doing in places other than the United States and how that's different than what we're doing here. Just as a quick aside, we was talking about the success of being able to transplant a patient who has a 90% sensitization is just remarkable. You have almost a sense of inevitability if you list one of your patients here in the States with a 90% sensitization that they're going to end up just dying on the wait list. That being said, one of the things I think is interesting and a really challenging question to answer is how do you deal with the timing of a transplant in someone who's doing well? So if you have a young Fontan who's otherwise doing well, you don't want to transplant them when they're doing well because you know that there's a certain lifespan for their allograft. Even though that allograft may last longer than a 70-year-old who gets transplanted because they die of other reasons, it's not transplanting somebody who's 25 years old. That heart is not going to last until they're 75 years old. You're going to end up potentially transplanting this person 2-3 more times in their lifespan, which may be a real challenge, both from a sensitization perspective, from a surgical risk perspective, from the number of sternotomies they're going to have to undergo. And I think that trying to figure out that and making sure that you are metaphorically pulling the trigger at the appropriate time, it's a real challenge.
Andy, thanks so much for that. And, just changing gears, going from technical surgical transplant details to now refocusing back on the patient. We know that having a heart failure diagnosis carries a major prognostic significance. And unfortunately, being diagnosed with heart failure is now a terminal diagnosis with outcomes similar to many cancer patients. So Andy, how do you begin to have these difficult conversations with your patient in clinic, especially since some of them are generally pretty young patients?
So discussing transplant and heart failure in a young patient is, I think, really challenging. And I think this is where the introduction of palliative care into adult congenital heart disease is potentially really underutilized and can be really beneficial for these patients. So starting off with just assessing where is the patient in their understanding of their condition, what the trajectory is of what their disease process is going to look like over the next 10, 20 years is generally where I start. And then early on, introducing the idea that your patient with a Fontan is not going to have a normal lifespan, but stressing that there's things that we can do, including transplant down the road, that may help them live a more normal life and live a longer life. And starting that conversation early so that they have time to process it and think about it before they're stuck in the situation where they're profoundly symptomatic and never has really thought about what would their life look like with a transplant. So getting our colleagues in palliative care and even those few people who are doing great work in ACHD palliative care to help them better understand what their disease process is, what their options are down the road is really important.
I cannot agree more with what Andy just said. If anything to add to what has been said is that I think as ACHD physicians, we have a massive responsibility to discuss this with our patients. And the question that always arises, when do you talk to a patient about transplant? And I think I probably do it in the day 1 or day 2 that I meet them, depending how much the patient is mature and how much the patient that knows about their condition. But I do it quite early, and depends also how you present transplant to them. So if I put a patient, a Fontan is transition, I see them in my ACHD clinic, maybe not the day 1, depending, sometimes it's the day 1, depending on how much the patient knows about the condition, as I said, but quite early, I try to tell them, look, you have a heart that's not going to last forever. It's going to take you to, I'd never say an age, but at some point you might need, a new heart. And I try to present transplant to them as an option that we didn't have some years ago. And it's an option that actually we have good numbers. And despite of what Andy said, that we don't yet know when is that time to trigger the transplant referral, it's good to involve the patient very early for them to manage their expectations in life. I think one of the most frustrating things for a patient, or in my experience, is that's coming to a situation where they need a transplant. They are referred to the transplant team. I have had this situation in my clinic. Say, well, nobody had told me this. So nobody had told me that I would need a transplant with 30 years old. And I feel deceived by the doctor. So I think if we get the concept earlier, and when they start not to do well, involve early palliative care. I don't think palliative care needs to be involved in patients that don't need a transplant, and we have no other options for them. I think palliative care should be part of the tier within the transplant assessment, because as Andy mentioned, they have more resources how to discuss with them how to deal with this awful situation in their lives. These are very young patients. But one of the key factors is to introduce the concept of transplant early in their lives for them to manage their expectations. Something as simple as, when do you decide to have a child? So that's, unfortunately, I discussed that with my Fontan patients. Unfortunately, you do not have the choice of deciding whenever, because your Fontan might not be okay by the time you decide to have that. So even if you have a 20 years old in front of you that doesn't have a partner, of course, in their heads not to become pregnant, I think it's fair to tell them, look, this might be a problem. You might choose to ignore this, but at least I gave you the information. And yes, with this information, you will manage how you want to deal with your life. So I think these concepts are important. So we, as our providers, should take responsibility of informing the patients of what might or might not happen in the future, for them to make an informed decision of what decisions they make in life.
Thank you both for those great points about some of the shared decision making and really empowering our patients to make sure that they understand their anatomy, physiology, complications, as Andy said, trajectory is really so critical as part of this process. So for our listeners, I'd like to ask you both, Andy and Dr. Alonso, What are some big takeaways for you who are straddling these two fields of adult congenital cardiology as well as advanced heart failure in terms of where the fields go in the future?
I think that one thing that we have not discussed much today, but I think is something that we have to work on more, and some data coming out, is the mechanical support in this population. As Andy said, these are patients that, you don't know when to trigger the transplant assessment. And it's true that the allograft has a limited time lifespan, but there's a group of patients that are not going to be transplanted either. So I think where the use of mechanical support in patients with congenital heart disease in general are more challenging within the frontal population, I think can increase their chances of surviving while they're on the waiting list to have a heart transplant, despite of all the complications that you can have on mechanical support, but also might give a chance as a destination therapy of those patients that might not have the transplant option because of high sensitization or because of renal dysfunction or comorbidities that might not be, or even for anatomical reasons that they cannot have a real sternotomy. So I think that is one of the areas that we have to have more research on that area. And the other area, which I think we will have less advances, but we would love to have, is medical therapy. I think medical therapy is going to be very challenging to find evidence in medical therapy because of the very small population, but also of the heterogeneity of the population. We said that the congenital heart disease patients are heterogeneous, but if you get just only the fontans, two fontans are not the same. It's not the same to have a systemic RV that having a single LV, or I personally don't think it's the same to have a left atrial isomerism than having a side to solid. I think that every patient is going to be different. The venous circulation that they have, how many collaterals they have, how the cardiac output goes around the heart. So I think it's going to be extremely challenging to have a medical therapy-based evidence for this population, but it's something that I think we have to try to work on, but with a very open-minded and forgetting that about guidelines. It's just thinking outside the box. The only way, in my opinion, of advancing in the field is having people that think outside the box. If we try to be very strict in what we apply to these patients, I don't think we would get very far.
I'll just add that I think that it's a really exciting time to be getting into the field of adult congenital heart disease and heart failure in this population for exactly the reasons that Dr. Alonso has already noted. And it's really exciting to see the advances we're seeing in the mechanical circulatory support for this patient population that really has extremely limited data. But I think some of the things that you hear about in either individual case reports or limited case series gives me a lot of hope for those patients for whom transplant is not going to be an option. As far as the takeaways from this, I think that the things that I would stress is really having an early integration between the ACHD team and your heart failure team, and recognizing those patients who need to start a heart failure evaluation and start thinking about that question of when is transplantation going to make sense, and is transplantation going to make sense for this particular patient. And that's a challenging topic and a challenging conversation to have. But I think the earlier you can start that conversation, the better. The other part that I think this is more speaking as the group as a field, I think that we need to have more conversations between the ACHD community and the heart failure and transplant community. We have to answer the question is, how do we want to approach this unique patient population that is only going to continue to grow in the coming decades as regards to our policies approaching heart transplantation? And that's different in every country. And the answers we have are going to be different for every group. But I think having that conversation about how are we going to make sure that we have equitable access to organs for patients with congenital heart disease, and how are you going to be able to fairly weigh the risks of transplanting these patients, or potentially how are we going to make it easier for transplant centers to do transplants in patients with congenital heart disease without having this ever-present threat of adverse outcomes, ultimately threatening their transplant program and making them more risk averse to doing transplant in the future.
If I can add something to that, I think one thing that is important is that we need to increase our international collaboration. So as Andy said, every country face different problems because of their different rules, but I think that international collaboration might help to change within your country what is needed for these patients if we have more evidence of what is doing somewhere else that works. So I think international collaboration is key, and we should talk more among us instead of just talking about only heart failure between the congenital heart disease doctors. I think that is extremely important to have international collaboration between the ACHD and heart failure teams to move this field forward.
Thank you both. This has been a tremendous discussion. And I'd add, I do a lot of moonlighting on our EP service. And so we have plenty of patients that come through with adult congenital heart disease that are getting upgrades or device changes, a lot of device therapies. And sometimes we're titrating their, heart failure regimens as they're here, again, with help. But it's another endpoint to, notice, like, if your patient is being treated for heart failure and they have adult congenital disease, this is another opportunity. I know they just came in for, a generator change or something like that, but this is another opportunity to just ensure that they're plugged into a adult congenital specialist so that they get a full holistic comprehensive care viewpoint. And, I just am so appreciative of being part of this discussion. And you really have exposed me to so many nuances that go into the discussions and also planning and details and postoperative planning of patients going through advanced therapies evaluation with adult congenital heart disease. So this leads me to ask Dr. Alonso, our favorite question that we ask our experts is, what makes your heart flutter about taking care of patients with adult congenital heart disease?
Well, probably what made me flutter the first day I started to do this is that every patient is a challenge. So since I was early in my training, I hated guidelines. I still hate them. And that's what makes a huge challenge in congenital heart disease, but also what makes the field exciting is that we are writing the guidelines. So it's a field that we do not know what we're doing. We are trying our best, and we try to offer our patients the best of what we can. But actually, the field is evolving every day, and every patient is a new challenge. I think that's what makes me more excited about the congenital heart disease field. And that's why I went into heart failure and congenital heart disease, because even within congenital heart disease, heart failure is completely uncharted territory. And that makes me really excited about it.
Well, thank you very much. And for our audience, not only does it make Dr. Alonso's heart flutter thinking about this and talking about this, but it also makes his eyes bright. He's just so excited to give us his time. We could tell that this is a very passionate subject of his. So this episode really highlights beautifully that adult congenital heart disease is such a broad field with so many overlaps with specialties and subspecialties and even subspecialties. Andy, we'd love to hear about your experience as an adult congenital heart disease fellow and career plans moving forward.
I have to say it's been a lot of fun. It's been a long road to get to this point. Much like Dr. Alonso, I kind of accidentally ended up in congenital heart disease, and that I did a clinic with my mentors, Ford Ballantyne and Heather Bartlett in Wisconsin, and just found that I loved working with this patient population. And there's such a need for it, and they've just been so incredibly appreciative. But to be able to make a true impact in these patients' lives on a daily basis has been so incredibly rewarding. And then doing heart failure and congenital heart disease has been a really rewarding process, but also incredibly challenging. As Dr. Alonso pointed out, there's not a lot of people who are doing this in the world. I've been really lucky that I had the opportunity to do an additional year of heart failure and transplant fellowship before my congenital training. And as I move here into my second year of ACHD fellowship, starting to think about what the long term is going to be and trying to find somewhere where I can help kind of move the field just a little bit further in the world of congenital transplant. So starting to look at that process, but excited that I think that this is a really great time to be getting into this very unique subspecialty of adult congenital heart disease.
We need more people like you.
I couldn't agree more.
So, well, I want to congratulate you publicly for doing this, because I think that is what I make the field to advance, is having people train in both fields that actually know what they're talking about, because this is really, really important. So congratulations, Andy, for prolonging your training, but I think that for a good cause.
Thank you. I wouldn't do it any other way. It's been fantastic.
Well, it's been so much fun chatting with both of you today. Thank you guys so much for joining, and thanks to all of our listeners for listening along with us.